The other thing that I don't like about PRP, so that was point one. Point two
That was point one.
is that it's similar to what you said around the education piece, is it's telling the message that we're going to fix the tendon with an injection. And even if we could fix the tendon, and this is what I say to them, I go, even if I waved a magic wand, made your tendon look amazing, in 6 months you'll be back because you don't have the knowledge around the loads and you don't have the strength in the tendon. So even if we could fix it 100%, we may as well just book your future appointment because you're just going to end up back where you were, because all of the supporting structures for your tendon, as well as how you would train and load, are still going to be the same, and that's what got you into the mess in the first place, not the fact that you had a funny-looking tendon.
Agree. And so when anyone asks me about adjuncts, whether it's, students, patients, athletes, coaches, the way I like to think about it is, what are they coming to me for? They're coming to me for pain and changes in function. And, we also have changes to the way the brain controls our muscles and our movement as well. So we have these 3 areas that overlap, and PRP doesn't actually address any of them. And so we can say that about any of these adjuncts, and that's why there isn't good evidence. Sometimes people will say to me, I had a PRP and, I did really well. And then I might have a conversation with them about load and capacity, and they often come to me and then say, do you think it was actually the rehab and the downtime that it gave me to recover my tendon? And it probably was the rehab. So one of the ways to think about putting adjuncts in kind of context for people is to explain load and capacity. And humans are complex. So I'm not just breaking people down into 2 hands, but it can kind of help meet them at their story. So if we imagine that your capacity is only ever just more than the load you put on it, that's true for any musculoskeletal tissue, bone, tendon, muscle. If you overload, so you increase your load and it exceeds your capacity, you'll have some sort of musculoskeletal issue. Let's say it's tendon. If you then rest, your load drops, your capacity also drops. So what I'll do is I'll actually meet that person at their story. If they've had multiple PRPs and downtime, I'll actually show them that that's what's happened to their capacity. It also really helps then saying what's the only thing that's going to help your capacity, and it's load. So interventions that empower people, that allow them to load, that don't cost a lot of money, I'm okay with. But anything that is expensive, lacks evidence, is risky, gets in the way of loading, we can't justify it.
Yeah, and one of the things I love to do is I love to get some form of strength metric as well to inform this conversation. So I love when I do my strength testing, and we'll go into some of the interventions that we do for strength, but I would do the same thing just to get a measure of what their capacity is. And if they've got, let's say, a 30 or 40% difference between sides, I'll say, was that painful? And they'll go, if it's a tendon, no. I go, okay, so if we injected something into your tendon, do you think that's going to help you lift more weight? And they'll go, well, no. And I'm like, that's the issue, is that even fixing or trying to change that structure isn't addressing those flaws in the capacity. And we've got to get way better at doing that and making sure that the public and the patients are aware that we need to do that.
Yeah, agree.
So
actually, just one more thing on injections. I don't want anyone to think that that is us having a crack at any of the medical colleagues that, do injections. And particularly if people have had like multiple injections, I think that, the ones that have failed conservative management,
it's on us.
Yeah, it's on us. And so they end up, seeking these invasive, expensive interventions because they've failed physio, and that can be a failure of the diagnosis. It can be the rehabilitation. So, it's definitely not a shot at anyone. It's more, how can we do better? Because I don't think people seek an injection first is what I'm getting at. Yeah,
and I think the other thing is, and I've had doctors, like I've had sports physicians call me being like, I'm sending you a patient, can you please see them? And I've just given them a PRP. And I'm like, well, why did you do that? Because I'm usually quite thinking, and they go, this patient doesn't stop. Me giving them a PRP and telling them that if they ever want to get better, they've got to deload and follow everything you say following this is the only way this person was actually going to have a rest.
Yep.
And I'm like, medical legally, that might be questionable, but from a treatment outcome, those people do really well because they actually do
They follow the rehab.
instructions. They don't overload. They have a lot more awareness of the loads and making sure that they're not overdoing it and stuff.
The challenge that I have is, I'm clearly biased because I see the people where everything's gone wrong.
Yes.
But I've seen people that have ended up with they've ruptured their patella tendon, they've ended up with chronic pain, so I'm biased.
Yeah, and I think the rupture is something that is particularly concerning because there's not anyone that I'm aware of now that would still inject into the tendon with cortisone, but the PRPs go straight into – oh, really? So the PRPs go straight into the tendon, and I just remember years ago Jill telling me or showing me some images from a study they'd done where someone had some PRPs and stuff years previously.
You could still
and
see
you could
the needle
see
track.
all the track marks from the needles from several years ago.
So we do think about something either works or it doesn't, and we often forget about that whole other category of adverse events. Yeah, the tendon knows about it for sure.
Yeah, so that's where I would definitely not do it. And I think with my practice of getting their capacity lifted but also empowering them with the education so that they know how to make the right choices, I haven't really needed to get people off for injections for these types of pathologies.
I remember seeing a volleyball athlete who actually flew down from Queensland, this is years ago, and he'd had 18 PRPs into each patella tendon. And the very first question I asked him was where his pain was, and he covered his whole kneecap with his hand. And so it was clearly quite diffuse then. So I said to him, has it always been like that? Did it start off a little bit more specific? And he's like, no, that's always been my pain. So he'd had 18 injections into something that wasn't even a tendon. But then, and his quad is terrible. The other thing that can happen with an injection is you can end up with a very complex pain presentation as well. Anyway, we've bagged injections enough.
Yeah, but I think it's more, and I would put most adjuncts in that basket, is that
I agree.
I think if you do a really well-structured load program and you get your education right so that they're managing their loads and they understand, you're going to find that the question of whether injections work or not is almost irrelevant because you've sorted everything out.
Yep.